Hello and welcome to Attentive Healthcare Solutions webinar, NCQA PCMH Certification for NextGen Enterprise. My name is Chelsea Grover and I'm the Marketing Communications Manager for Attentive. Before we get started on today's webinar, I wanted to take a moment to explain the process for the presentation. First, I'd like to mention that this webinar will be recorded and that we'll send out a copy of the slides along with the recording within the next week. Next, for those of you who aren't familiar with Attentive, I wanted to share a bit of who we are with you. We specialize specifically in NextGen Healthcare, and we're passionate about providing solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything NextGen. Oh, and we also have some add-on productivity solutions for NextGen, including ChartGuard, Refund Manager, Unapplied and Deposit Manager, and Multiple Encounter Billing Manager. If you'd like any information on those add-ons, feel free to drop us a note in the webinar and we'll make sure to send some to you. Next, I wanted to mention some upcoming webinar topics that you can expect from us in September. First, we'll be presenting Demystify the API. It's going to be fire. In it, we'll be covering everything to do with APIs, including what they are, how to use them, and the new information blocking regulations surrounding them. Then later in the month, we'll be presenting Streamlining Patient Intake using Instant Medical History in NextGen. So keep your eyes out for the registration announcements on LinkedIn and via email. Okay, so back to today's webinar on the NCQA PCMH certification for NextGen. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning is Manager of Client Development and Carly Hogan is Client Solutions Administrator at Attentive. So they're both subject matter experts on PCMH certification for NextGen and are eager to share their knowledge with you today. So Lindsay, let's jump right into it.
Great. Well, thank you, Chelsea. And hi, everyone. Thank you for joining us for our webinar on the transformation as well as annual reporting for NCQA PCMH. So today's presentation will be beneficial, I guess, in my opinion, no matter if you are already part of a PCMH currently or if you're considering becoming one in the future. Either way, if you just don't feel like you have all the information you need to ensure your success, you've come to the right place. We're going to address questions and concerns of PCMH transformation, as well as the annual reporting process and requirements, as well as mention the changes for 2022 and the ongoing COVID-19 impact. We really understand what's required here. We work closely with NCQA. We have best practices to be successful using NextGen specifically, and we understand how to make your practice and providers more productive and profitable. That's our goal. Now, as a disclaimer here, I think you probably all picked up on this, but we are strictly focusing on NCQA PCMH program. No other type of PCMH recognition will be covered. Although I will say many of the general concepts we cover in regards to practice benefits. Right here at the beginning, we'll talk about ROI on PCMH and of course, elevating the conversation. That would apply to different PCMH programs. So I thought it was important to point this out sooner rather than later. I also wanted to note that as an NCQA PCMH CCE myself, I have access to some amazing resources and in-person training that I attended. And that all largely fed into this webinar. So most of the graphics and a lot of the overall content has been taken directly from NCQA in order to provide you with the most consistent and accurate information possible. One of our goals with this webinar is to make all this information a lot easier to dissect and digest. So where I had, I think 4 to maybe 500 plus slide presentations from NCQA when I was there, I was really able to try and, with Carly's help, scale it down and pick out what you need to know and add in what you should know. So this means a lot of the takeaways and tips, like I said, are coming directly from NCQA evaluators who actually conduct that transformation and annual reporting requirement review. So up first on our agenda today is just introducing or reintroducing you to the PCMH basics. So if you are already a PCMH and you've completed transformation, this is likely going to be a review. It'll go pretty quickly, but I still think there's some great information in here to reiterate the importance of this program in your practice and maintain your practice support. It'll also serve as a great refresher to you on what's required until we get to the annual reporting section, where I know some of you are currently gearing up to complete as well. So for those of you on the call who are not yet recognized, or you're kind of a PCMH newbie here, you may be wondering what exactly this is. Well, the patient-centered medical home, or PCMH, is a care delivery model where patient treatment is really coordinated through the primary care physician to ensure they receive the necessary care when and where they need it and in a manner they can understand it. So the objective is to have a centralized setting that facilitates partnerships between individual patients and then their personal clinicians. So this is going to emphasize care coordination and communication to transform the care you're currently delivering based on the patient's preferences and needs. So in summary, I would say PCMH really is a model of care that puts the patients at the forefront of care or at the center of that care. I also want to note, because I get this question a lot, PCMH recognition is completely voluntary for practices. You choose to participate. It is not required, but it does put your practice at an advantage in a ton of ways, which we'll actually go over in a few slides of how to recognize and relay the value of PCMH to your team. So how do you gain buy-in at your practice if you're new to PCMH? Or on the flip side, how do you sustain support if you are already recognized? Well, I would probably start with these main points. First is going to be reduce fragmentation and improve quality of care. This is going to emphasize a team-based care, communication and coordination, which I think is a no-brainer. It's going to lead to better healthcare for a patient. Higher rates of fragmentation are often associated with higher healthcare costs, lower quality of care, and higher rates of preventable hospitalizations. Secondly, many payers acknowledge PCMH recognition as a hallmark of a high-quality care practice. Earning PCMH recognition means you're providing patient-centered care that's associated, again, with that higher quality, better patient satisfaction, and it typically means a reduction in those, like I said, avoidable, costly visits to the ED or the hospital. So as a result, many payers will actually provide incentives to PCMH recognized practices and offer benefits ranging from enhanced reimbursement to preferred provider status. We've also found that this can actually help you better negotiate your payer contracts. And I think it goes without saying the PCMH model is also associated with better staff satisfaction and a better patient experience. As you can see, there are numerous other benefits we've listed on your screen. You can use these as tools or conversation starters to elevate the conversation and gain buy-in, but we won't go through all of them. Now, if your providers are still questioning you, I would give them these details on clinician benefits. And again, I would start with our first bullet here. It's likely to catch the attention of most providers or clinical staff and gain that buy-in with earning higher reimbursement. So I know I just mentioned this, but it's true. The majority of payers nationwide offer either enhanced reimbursement, so you're going to have that higher reimbursement coming back, or that better payer contract for recognized clinicians. Or they even provide support for practices to become recognized. Second is still a big one here, succeed under MACRA. So obviously, I think we're all familiar with CMS's quality payment program. You have the MIPS side, you also have the advanced payment model side. NCQA's PCMH program specifically is acknowledged by CMS as a way to receive MIPS credit. So you're automatically going to earn full credit in one of the MIPS categories, the improvement activity category. And by the activities that you're doing, it's likely also going to help you in your quality and your PI category, as well as your cost category. Another big one with providers is earning maintenance of certification credits. Several medical boards award clinicians in NCQA practices MOC credits, reducing that burden on your clinicians to take any additional activities or education. This also is a great segue into reducing burnout. This model itself ensures that team members operate at the highest level of their knowledge and skill set and within their license. So with this, physicians don't want to do what nurses can do, and nurses don't want to do what front desk staff can do, etc. So there's more time for patient care, and also you get a more satisfied care team. This model is going to help streamline your processes and standardize your procedures, which you'll see right off the bat with some of the core criteria. So a lot of providers also like to use this recognition as a time to perform a gap analysis and to implement those processes and procedures that will improve care and really make your practice run much more efficiently. And then last but not least, to really gain buy-in here, Another kind of important factoid that I would absolutely highlight is the ROI on PCMH. Practices that implement the PCMH model need to consider the business impact from investing in PCMH and effectively, planning for how that implementation will impact you financially. So you have to ask yourself, what are the operational and financial considerations for becoming a PCMH recognized entity from the perspective, of your primary care practice as a business. So think of cost. This could be anywhere from new systems, structures, or processes that are put in place. But the big one that I've seen a lot is potentially the cost of staff, either hiring other staff, bringing in, an external consultant, et cetera, needed to support that transformation. So to identify the potential business impact, NCQA actually engaged Milliman, which is the world's largest provider of actuarial services, to answer this question. So they actually modeled the impact this would have on revenue and costs at a hypothetical practice with 10 primary care clinicians and about 20,000 unique commercial members. And they concluded that the revenue impact of this recognition for that hypothetical practice was between 2% to 20% increase in revenue. It really depended on the payment model. But the main takeaway here is that in all payment models, revenue increases for a hypothetical practice outpace the cost, resulting in a positive ROI. Truly, I think a lot of practices who are considering PCMH recognition aren't sure, how to relay the value to upper management, or, you're often tasked with the burden to prove why this would benefit the practice and its patients. And even practices who already have the recognition and are phasing into annual reporting, we're finding more and more, especially in light of the current environment now surrounding COVID-19 and lack of resources and funding, we're finding that they have to defend their PCMH status to management, and they're asking why they're doing this and to prove its worth. So we wanted to provide you with the tools to elevate that conversation. So now on to the recognition structure, just as a high-level overview of eligibility and the process to start with. So I already mentioned we would be focusing on specifically the NCQA PCMH recognition. And that's because NCQA offers the most widely used PCMH recognition program for providers. It's using standards which were actually redesigned in 2017. Prior to that, they were the 2014 standards. Now again, NCQA's PCMH is definitely the most widely adopted PCMH evaluation program in the country. I will say other accrediting bodies like Joint Commission, URAC as well. There's also a number of local, state, and national PCMH recognition and accreditation programs. And there are even, I've seen some payer-specific PCMH programs and worked with a few of those. However, NCQA is the gold standard. It is what almost all EHR vendors recommend and work with, which is why I said in the beginning, if you're participating in one of those local state, I know New York State has one, or a payer PCMH, this webinar will likely still be helpful to you because so many of their requirements will probably align with NCQA. So if you're asking yourself, this all sounds great, we love the introduction, but let's get to it. I'm more interested in knowing, where do I even begin this process? So the first place I would start with is eligibility. So clinicians who are eligible are those that hold a current unrestricted license as an MD, a DO, an APRN, or a PA, a physician assistant. Only clinicians who can be selected by a patient or a family as a personal clinician are eligible to be listed. Now, an eligible practice is going to consist of one or more clinicians, which includes all eligible primary care clinicians, who practice together and provide primary patient care at a single geographic location. So practicing together is actually going to mean that all the clinicians in a practice follow those same procedures and protocols, and they have access to and share medical records for all patients treated at the practice site. These also need to be outpatient primary care practices. And a practice in NCQA's eyes is a clinician or clinicians practicing together at a single geographic location. So to be specific, this can include nurse-led practices in certain states. However, it does not include urgent care clinics or clinics that are only open on a seasonal basis. Now, it is important to note that recognition is achieved at the geographic site level. This means, kind of the easiest way to describe it, is one recognition per address. And all MDs, DOs, PAs, and advanced practice nurses at that address are listed on the application, since all eligible clinicians at a site have to apply together. So clinicians should be listed at each site where they routinely see a panel of their patients, and any non-primary care clinician should just not be included. So this means at least 75% of the clinician's patients, if they're going to be considered, a personal clinician or a primary care clinician, should come to them for a first contact for care, should see them for continuous care, and provide those comprehensive primary care services. And obviously, should identify them as their PCP. Now, there is multi-site eligibility available, but you have to answer yes to all three of the following questions. So first is, can your organization sign one PCMH program agreement to cover all sites applying for recognition? The second is, do all practice sites applying for recognition share and use in the same way a PM system or an EHR to document patient care for admin and billing? And then lastly, do all practice sites applying for recognition operate under at least some of those same policies and procedures? So if you can answer yes to all of those, you are eligible for multi-site recognition, which means you can share credit for things across all those sites. So you would have one primary practice that submits all the evidence, and that can be shared by the rest. Now, there are some criteria that are site specific, so you'd have to submit on those kind of like satellite sites as well. But overall, this makes the process much easier for large multi-site practices. Perfect. So I'm going to actually go ahead and hand it over to Carly, who actually just finished taking a NextGen client through the entire transformation process and successfully got them recognized to review the scoring structure and look at these standards more closely. So Carly, it is all yours.
Awesome. Thank you, Lindsay. All right. So once you determine if you are eligible to become a PCMH, the next step is understanding how that recognition works and what your practice will need to do to meet the requirements. So first, let's take a look at the structure of the program and how it's set up. The program has evolved to feature a set of 6 concepts that make up a medical home and are the overarching themes of PCMH. And to earn your recognition, your practice has to complete criteria in each concept area. Next is competencies, and these are used to categorize the criteria. They do not offer credit. They're more just a way to think about grouping the criteria together. Then we have our actual criteria, which are the specific activities in which a practice engages to demonstrate that it meets recognition requirements. So these are the individual tasks or things that you do to make you a PCMH and actually transform your practice. Then lastly, within the criteria are components, which are the individual part of the criteria where the evidence is attached. So credit is assigned at the criteria level, and evidence to support that activity is attached to a component. It took a little bit to conceptualize this and really get a grasp on how it works, but once you really dive into the standards and guidelines, you'll really understand how this structure functions. So our 6 concepts or overarching themes are pretty straightforward. And we actually wanted to select this graphic with the different shapes and sizes on purpose so you can see which ones have the most amount of core criteria found in them. So you have team-based care and practice organization, which focuses on things like practice leadership and care team responsibilities. So you can see it's a smaller square, which means it has a lot less criteria compared to the other standards. Next is knowing and managing your patients, which deals with things like data collection, med rec, evidence-based clinical decision support. And you can see this is the largest category, so it's going to have the most core criteria in it. And then you can see the other additional categories there on the screen, and based on their sizes, kind of shows you how many core criteria are in each area. So then you'll see for every criteria a breakdown just like the one above. You have your concept, which uses a 2-letter abbreviation when identifying it, such as TC for team-based care. And then you have your competency, which is just the criteria subgroup. Then you have the actual criteria, which states the PCMH requirements, which is always shown as the two-letter abbreviation, then number. So TC01, for example. And then you see you have evidence, and under that evidence are two components listed that you'll have to attach evidence to get credit for that criteria. So yes, it sounds confusing and like a lot when you talk it out, but I do think this visual really helps to break it down, and it makes it more meaningful to see how this structure works. So to receive recognition as a practice, you have to complete all 40 core criteria, and then you can earn 25 elective credits. So elective criteria are a mix of 1 to 2 credits, and they have to cover 5 out of those 6 overarching concepts. Each criterion in the standards is noted with its assigned value, and you can see on the image there that it's showing how many credits are available under each concept and competency. So you have 40 core criteria and then 60 electives available where you just need to get 25 of those credits, so 25 out of the 60. So this is just another graphic to better understand how the elective scoring works, and also one that shows you the breakdown of core criteria within each standard. So it'll show you exactly why I made the blocks different sizes on that previous slide. For example, you can see KM and QI clearly have the most required core criteria as compared to TC or CM. So you may be wondering, okay, how do we meet this criteria, or how does NCQA know that we met it? And that's where evidence comes into play. So practices must submit evidence demonstrating their performance against specific criteria. Practices are encouraged to implement and document process-based evidence early in the process, at least 3 months prior. And generally, your reported data should be no more than 12 months old. So think of it like an audit. You have to back up and prove you're doing something. It's just really the same idea to prove that you're actually meeting the criteria that you selected by submitting your evidence. There's then 2 types of evidence. So we have documented processes and evidence of implementation. For the documented processes, these are written statements describing your practice's policies and procedures. So whether it's a protocol, a practice guideline, or an agreement, it could also include things like referral forms, checklists, flow sheets, etc. We then have evidence of implementation, which is kind of the catch-all for everything else. So it could be reports, screenshots, patient records, ECQMs, data entered in Qpass, and NextGen transfer credits. So you can submit this evidence either online through the NCQA PCMH portal called Qpass, or through what is called a virtual review, which is basically just like a Zoom call with an NCQA evaluator. Now, with Qpass, you're uploading things like policies and procedures, practice pamphlets, or a link to your website. These are things that the evaluator can just review on their own time, and they don't need an explanation from you. So it's convenient because you can also upload it once and then link it to additional criteria. So if you have something on your website that meets 2 criteria, you would just upload the link once and then link it to both. It's very important that you do not upload anything with PHI on it. If you do decide to upload screenshots from your EHR to meet a criteria, you would just need to make sure you black out the PHI. Which brings us to our second type of evidence submission, which is the virtual review. So practice has 3 virtual reviews, and during these calls, you are screen sharing with the NCQA evaluator, and you're on the call with them. Here you don't have to hide any PHI, which is why these EHR demos can be a lot easier to meet, and they're encouraged during the virtual review rather than submitting them on Qpass. And we're going to cover reviews in detail coming up shortly with some best practices and tips and tricks that we've gotten from multiple NCQA evaluators. Now, if we really look at a standard altogether, we have the concept, the competency, the criteria, and then the evidence required to support that criteria being met. Then you also have guidance from NCQA, and guidance includes things like information on the intent of the criteria, expectations, how the criteria relates to other criteria, terms used, and just aspects of the evaluation process. And you'll find that the guidance is extremely helpful, so be sure to not overlook it. But that's it. That is how you determine what is required of your practice to become a PCMH. It's the transformation of your practice to meet those requirements and provide evidence to support your activities that will earn you recognition. So now it's just the actual process of how to gain the recognition, where to go, and what to submit. So I'm going to go ahead and turn it back over to Lindsay briefly before we get into how you would actually get credit for the criteria.
Great, thank you, Carly. So again, we'll kind of breeze through this, more of the recognition basics and the actual review process of what happens during those check-ins and once you actually submit your criteria. Then we'll jump into some examples of how to meet criteria, which I'm sure most of you, if you are transforming on the call, would love to see. So first off, you need to determine if you're eligible, which we talked about. It's also recommended to perform a gap analysis of your practice and identify where you might need to transform. Comparing yourself, I like to start out with the core criteria. So in that analysis, you're looking for things like, does your practice have leadership in place? Do you have a designated PCMH team or lead? Do you have a physician champion? Do you have a certified EHR? I imagine most of you on the line do have NextGen in place, and NextGen does have pre-validation transfer credits to consider. Do you have a communication plan to engage patients? So basically a patient portal. Is your website up to date? Do you participate in value-based agreements supported by different payers or health information exchange? Do you report ECQMs to CMS under MIPS? So do you have the HQM installed? Is your practice knowledgeable of the concepts on PCMH and have already begun transformation? So those are things to keep in mind. You would then go ahead and enroll in the NCQA Qpass system. You would set up your profile by choosing your sites using your tax ID. You would add your clinicians to it. And once you have all that set up of the kind of the demographics of your practice, you would then actually sign the agreement and then pay the fee to start the 12-month transformation period. And this is why we say you should really have reviewed the requirements and then already started to make changes and getting things in place for this, for at least the core criteria before officially starting an NCQA's eyes, because that 12-month clock starts as soon as you sign and pay from that point forward. So you'll use that quality performance assessment support system, or Qpass as we've been referring to it, to gather your evidence, to upload that evidence, to prepare documentation, and also track your practice's progress towards your recognition. Now, once you are enrolled, so once you have signed that agreement and you've paid and you set this up, you will almost immediately be signed an NCQA representative, and that person, that rep, is your single point of contact to guide you through this process. Your representative will schedule an initial call to likely introduce themselves, discuss the process. They might help you develop a review schedule of those 3 check-ins that we've talked about. Overall, your NCQA rep is your best friend. They are your lifeline, and they are your best resource. They are your biggest cheerleader in this process. They are not the ones conducting your virtual review. An NCQA evaluator will actually conduct your virtual review and determine if you meet criteria or not. And you will not meet them or speak to them or be able to ask questions to them anytime outside of one of those 3 check-ins. Now, once you've completed your check-ins and earned your recognition, each year after the practice then checks back in with NCQA to show its ongoing activities are consistent with that model of care. This is part of the annual reporting process. Back in the 2014 standards, which we didn't talk about today, but you used to basically have to go through transformation all over again. So this is a major improvement with this annual reporting process. You're really just attesting to certain policies and procedures are still in place, and you're going to submit some data to them, very similar to the criteria that we'd already submitted for transformation, to prove that you're sustaining that recognition and fostering that continuous improvement. Now, the review process is the last and I would say most critical step. It's also the most, I don't know if I would say intimidating or feared step I've seen among practices, maybe because it's relatively new, but there are up to 3 check-ins. So during these, you really want to predetermine criteria to address. You're going to want to focus on core and documented processes first. And then after that, you're going to want to identify criteria for your 25 elective credits. So you're going to provide documents for offsite review. So those are going to be your policies and your procedures, your protocols. Carly mentioned a website link. There are some measures that might have an attestation to it. Those are things you're going to upload and provide beforehand. Then you're also going to provide evidence during your actual check-in or virtual review. So some ideas here: make sure you communicate with your evaluator. They are a human being just like you. Transparent communication is always going to go a really long way. You will be able to substitute evidence if something's not sufficient. They will tell you, this doesn't cut it. You need to have X, Y, and Z on here. Maybe a policy is missing a date. Maybe you need to show a few more patient examples. And they work with you and provide you guidance on what to substitute. This will be your time likely to demo your system, so to jump into NextGen and actually show them the workflow. As well as possibly provide reports. So if you didn't upload them or there was PHI in them, so you want to show them during the review, this is a time you could log into the HQM and have that, or have already run that report and have it up on the screen for them to see. So virtual reviews really give practices, immediate and personalized feedback on what's going well and what needs to improve. Again, they may seem intimidating. It's actually so much easier and better for you to develop a relationship and get that immediate feedback. On our last check-in with a client, we had someone showing evidence. She said, that's not going to cut it, but I would accept this. And while we were going through the rest of the criteria, someone else on the team was able to loop back and get the new evidence and show them in that same time frame. They really are there to help you, and they'll give you a good idea of what they're looking for or what they need to see. So like I said, we'll get into the tips and tricks on the next slide, but some things that really worked out: we had all resources on our last call that we needed. We had billing, we had clinical, we had IT, we had we had our external consultants and CCEs. We also conducted an internal, almost kind of mock virtual review before each one, so it went extremely smoothly. We had a plan to know exactly who would share their screen for a certain criteria and who was going to present what. And we were also able to complete transformation only using 2 virtual reviews instead of 3, which really took the pressure off. So I know I got a little ahead of myself, but here are some more of those tips and tricks. First off, you need to know these check-ins are limited to 2 hours. That's it. They will cut you off as soon as your time is up. Second, you need to know you have a maximum and a minimum number of components you can have at each check-in. So, it's not like you could jump on a check-in number 1, it could go for 4 hours and you could do all of your criteria that you've met. It's not going to work. You will actually mark items in Qpass to go over in the virtual review prior to meeting it. It won't even let you schedule it until you have those marks. So you will know exactly what you'll be presenting to the evaluator, and the evaluator, vice versa, will know exactly what to expect and will kind of guide you through that based off what you selected. So again, my advice is to try and complete everything in 2 reviews so you have an extra just in case for any straggler criteria. Otherwise, you have to purchase a 4th. So due to the time and component restrictions, this is why we said upload all your documented process beforehand. Also, transfer credit achieved by your EHR vendor, most likely NextGen in this case, which we'll look at later on, does not count towards your total component minimum or maximum. So this means you can mark all of those done and not include them in your total, which is a big benefit. Also, any shared credit, if you're a multi-site eligible practice, is going to be reviewed at one practice and then just automatically marked as met for the rest. Again, with this first check-in, only focus on core criteria. You have to get these done. Make sure to run any reports you plan on showing before the call. You don't want to waste precious minutes watching your EHR load on a long report. Make sure if you are doing a demo to have an actual patient example already pulled up, or if it's a screening tool being used to meet criteria, it has to be filled out. They're not going to let you get away with test patients or example surveys. They're going to want to see this in real practice. Other general tips and tricks include, like I said, have the right staff available. Have all the necessary people you need in the room. Nurse, if it's front office, if it's a workflow that they're familiar with. Billing, a clinician if needed. I mentioned your external CCE or consultant. We also had IT in the room because for kind of the next example here would be to check to make sure your Skype or your Zoom setup and mic connection is all set before the call. You don't want to be on the call and you can't see each other, or you don't have audio and you're wasting precious time figuring that out. So make sure you have your systems and your reports ready, 15 minutes prior to your check-in start. Keep your descriptions concise and to the point. Don't take my lesson that I do on these webinars and ramble a little bit. You want to keep your descriptions and your statements on proving this with your evidence very, very short, very concise, and let the evaluator know you know what you're doing. You only have 2 hours. You can revisit any criteria during that session if you have time. And again, these are all about preparation and organization to use your time wisely. You can get a lot done in 2 hours if you're prepared. Now, after these check-ins, the evaluator is going to mark your criteria as either met or not met. If it's not met, you'll just go ahead and add it to your list for your next virtual review and take the guidance that they suggested and apply it to go ahead and meet that the next time through. Now, after all 3 check-ins, if the practice has met all the core criteria and you have the 25 elective credits, the results are going to be forwarded to the ROC, or the Review Oversight Committee. They'll go ahead and finalize that decision. If the required criteria is not met in 3 virtual reviews, an additional is available for purchase. Same kind of idea here. If the survey process or if the transformation itself is not completed within 12 months from the time you signed and paid, additional time can be purchased. So we've taken you through, a lot of the actual process of gaining recognition as far as kind of uploading evidence and the virtual review itself. But we did want this to be meaningful to help you understand what NCQA is really looking for to actually meet criteria, using NextGen or at your practice. So we tried to pull 1 to 2 criteria, core criteria specifically from each of those to show you some examples of evidence. So I'm going to actually turn it back over to Carly, since she played, a big role in gathering evidence for our last client, to take us through these examples. So Carly, it is all yours.
All right, thanks again, Lindsay. So first we have team-based care and practice organization. And the first criteria we're going to hit on is TCO2, which wants you to define practice organizational structure and staff responsibilities and skills to support key PCMH functions. So you can provide an org chart to meet this criteria and upload it to Qpass. However, lesson number 1 with meeting your criteria is you really need to read and reread the description and take it literally. It says structure and role and responsibility. So that means if you uploaded an organizational chart that didn't list staff responsibilities under it, it would not meet the criteria. You need both parts. So look at the example image on the top. This has both. You could submit an org chart that just has role and name that shows structure, and then submit a job description for each role on the org chart. If you already have those, and that is lesson number 2, evidence is flexible. NCQA encourages practices to do what works best for them and to think outside of the box to meet criteria. There's no one-size-fits-all when it comes to evidence, and that's the point. It's supposed to be unique to what fits your practice. Another standard under team-based care is TCO9, which states that you need to have a process for informing your patients about the role of the medical home and provide materials that contain the information. So this screenshot is from a pamphlet given to all patients in the practice that explains what a medical home provides. You may also add a similar section to your website and then use your website link as evidence to ensure patients with and without internet access can access this. Again, flexibility. Moving on to knowing and managing your patients, and this is going to rely heavily on your EHR. So KMO3 asks you to conduct depression screenings using a standardized tool. And you can see I included screenshots of the PHQ2 and the PHQ9, but note that both examples are filled out. That's key for any screening tool that you show. It has to be filled in. You cannot submit a blank template for a screening or survey. Also, this one might be a good one to show during a virtual review as a demo. Another good lesson is to always pay attention to the components needed for each criteria. You might need a report and evidence of implementation or documented process, which means you have to have both things submitted before the criteria will be marked as met. And remember, you can always upload the documented process beforehand and then show the report or screening during your virtual review. KMO9 is asking you to assess the diversity of your population. Again, this is a simple report you could even make in Excel that uses demographic data to show race, ethnicity, vulnerable population, and language. All the required parts will be explained in the guidance of what exactly NCQA is looking for. And that's why we always say do not skip over the guidance, or you'll most likely leave out a key piece of information that they want. Next, we have patient-centered access and continuity. ACO1 is ensuring that your practice assesses the access needs and preferences of your patient population from collected data to determine if existing methods are sufficient. So if we look at that top screenshot, you can see survey result answers and then the pie charts that analyze that data. Now, what I want to point out here as a big lesson learned, especially in this standard, is that survey questions need to be actionable. So not just yes or no. So it can't be something like, would it be beneficial to open another practice location to better serve you? It has to be that question with the additional, if so, please list your zip code, so that you can actually be sure you're collecting actionable data. ACO5 asks you to document clinical advice and reconcile after-hours advice and care in patient records. This is a great example of having to show two components: documented process that states what the practice should be doing or what is the policy in place for this, and then the actual documentation in the medical record as an example of the evidence of implementation. All right, next up we have care management and support. So CMO5, does your practice provide a written care plan to patients, families, and caregivers under care management? Again, you don't have to overthink this. It's a good one to provide a patient example for during a review. So you can just show within one of your patient charts that a care plan was reviewed and provided. Then we have CMO3. So are you identifying your patients as high risk using a comprehensive risk stratification process? This one's a good example of something else that you might come across in PCMH. So there's some criteria that are automatically going to allow you to meet other criteria. If you meet CMO3, you're going to get auto credit for CMO1, and that's because CMO3 is more sophisticated. So it really is taking CMO1 to a whole new level by actually having a risk stratification process like NextGen Pop Health in place within NextGen. Okay, moving on to care coordination and care transitions. CCO7 considers your available performance information on consultants and specialists. Again, two great examples here, one being an Excel spreadsheet that tracks a bunch of different things, and this can likely be used to meet multiple criteria, which is great and essentially killing two birds with one stone. You could also go to Physician Compare and show data on the specialist your practice uses. Again, there's just a lot of different ways to meet every criteria depending on what's going to work best for your practice. Then we have CCO1, which is all about tracking, flagging, and notifying your patients of lab and imaging test results. So again, this one's likely dependent on your EHR, but you can upload the documented process to Qpass and then show your EHR example, like the one from NextGen on here, with the result in red. A lot of times these require both process and evidence. So you can see the level of detail on the documented process with the effective date and the issue date as well. And remember that these processes do need to be in place for at least 3 months to count. If you're having trouble with documented processes that you don't have but you need to create, these are some examples, but MGMA has a whole book of policies for purchase that you can review and tailor to your practice specifically for PCMH reporting. And this is also something a CCE like Lindsay could help you create as well. We're not suggesting you copy from online though. NCQA does hate templates, we can tell you that. And our last category is performance management and quality improvement. So for QIO1, you need to monitor at least 5 clinical quality measures across the 4 categories. And the categories I mentioned will most likely be explained in the guidance for this specific measure, but you have this met if you're using the NextGen HQM, so this is really an easy one. Then we have QI 15 and QI 18, which are to report practice level or individual clinician performance results within the practice for measures reported by the practice, and to report clinical quality measures to Medicare or Medicaid. So again, if you're using your HQM reports, that will work for this one. Or for internal, maybe you have like a monthly clinician meeting where you distribute the HQM reports and review them. Those meeting minutes and the reports would be great evidence. And then for reporting to CMS, you could screenshot your submission batch ID from the HQM if you submit under MIPS using that. So again, meeting these criteria, it's not about reinventing the wheel. It's just about making your practice more patient-centered. So if you're doing these things already, that's great. So we then have some key takeaways and themes for meeting the criteria and gathering evidence that we do want to share with you. First, your evidence can be flexible. I think we've said this quite a few times, but many criteria require multiple types of evidence as well. So again, you might have that documented process plus evidence of implementation. Screening tools and templates must be completed if you're using them as evidence. Remember that criteria focuses on the entire patient population. So a lot of times practices tend to collect data on a subset of patients unintentionally. So for example, the team-based care measure where we put the information on a medical home in a pamphlet, if you're only giving that pamphlet to new patients, that means that you are not focusing on the entire patient population. Now, on the flip side, criteria includes the verbiage vulnerable population. That should definitely be focused on. So the vulnerable population can really trip some people up. You need to make sure that it's based on your patient population. So some examples of vulnerable populations would be Hispanic versus single moms, or homelessness, or veterans. But if you compare things like literacy rates in girls versus boys, that would not count. So it sounds like an easy thing, but it really does trip up a lot of people. A couple other notes is just that documented processes always need a date of implementation, and they need to be in use for at least 3 months. So just make sure you have a date, in the header or footer of your processes. And then anytime you use data in your reports, it has to be no older than 12 months. So if you're showing patient examples on a virtual review, it has to be from the last 12 months. All right, so now we're just going to move into annual reporting. And if you're already recognized as a PCMH, congratulations to you. So we are going to talk about 2022 guidelines. These were just released in July. And of course, annual reporting is required each year to maintain your recognition. So annual reporting sustains a practice's PCMH recognition and encourages continuous quality improvement. And to meet these requirements, you have to attest to some policies and procedures and submit evidence to NCQA. As Lindsay mentioned earlier, PCMH was overhauled in 2017. However, NCQA did not want to leave practices who became recognized using the 2014 standards at a major disadvantage. So if you happen to still be recognized using the 2014 level 1 or 2 standards and you're approaching renewal, you would renew using a process called accelerated renewal, which, as you can probably guess, is going to allow you to gather less evidence than a full transformation from scratch would require. And if a practice is PCMH 2014 level 3, you can just transition directly to annual reporting. So after you're recognized, you have to complete annual reporting to maintain your recognition. And this has to be done 30 days before your anniversary date. So essentially 11 months after your initial recognition. If you really need to, NCQA can adjust your annual reporting date. You just have to submit a request to your NCQA rep with your reason for consideration. During annual reporting, you'll be asked to attest that you're performing activities that make up your PCMH requirements. And you'll also be asked to demonstrate that you're embracing measurement and quality improvement. In some cases, this could mean submitting evidence via documentation or providing measurement data. We do want to note that evidence can be provided at any point within the year, but it will only be reviewed after your reporting date has passed, so you can gradually upload this to the Qpass system instead of all at once. And from what I've heard from clients, annual reporting requirements really are flexible to meet your practice's unique needs. You're really probably doing most of it already. And as we mentioned, the 2022 standards just came out in July. So each year, the following years do come out in that July. All right, so what does the 2022 annual reporting process entail? So you have to submit the following in Qpass by your practice's reporting date, which includes an annual questionnaire and the evaluation, which is where you're answering questions, submitting data, providing explanations, etc. NCQA then reviews your submission and notifies your practice if you are sustaining recognition or if something else is going to be required. And the final decision is determined by the NCQA Review Oversight Committee. We do want to point out that 2022 annual reporting requirements have changed from 2021. So if your annual reporting is coming up, just make sure that you do review this slide and the requirements on NCQA's website. But overall, it's supposed to take no more than 15 to 40 hours of work per year to prepare for your annual reporting. And then the next thing that we just wanted to go over are a couple of the most common pitfalls. And just based on time, we're not going to review all of these, but really the biggest one is overthinking. Annual reporting is really not supposed to be that difficult. It's just supposed to prove that you are still doing what you are recognized to do. And also make sure you don't miss your annual reporting date. So it's 30 days before your expiration date or anniversary date, as we've mentioned quite a few times. And then the last thing is just don't forget to input information into Qpass. Okay, and lastly, with annual reporting is the word audit. So nobody's favorite word, but just be aware that a random sample of practices that submit annual reporting requirements are going to be selected for an audit. You'll be notified via email, and you're going to have to demonstrate core PCMH criteria. So audits are conducted through a virtual review by NCQA staff, and you'll be given information on what to expect and what to prepare for that. All right, so I know that was a lot, and now you might be wondering how the pandemic has affected the PCMH recognition process. So I'm going to go ahead and turn it back over to Lindsay to walk us through any changes that may have been announced related to COVID-19.
Great, thank you, Carly. So first off, we're going to quickly look at the COVID-19 exceptions. NCQA has implemented some exceptions for the time frame between March 1st, 2020 and December 31st of 2021 this year. So that was actually originally set to expire on September 30th, and then it was updated in April with that extension. So all in all, they haven't really changed much. I included the screenshot from their website so you have the exact verbiage, but they've just stated that they understand all more operations have been disrupted. Obviously, this is going to affect practices, so they're willing to be flexible in their scoring during this designated time frame. I did want to make note of what's italicized on that screenshot. They just included a nice subtle reminder that recognition practices can show evidence from any time in the past year. So, you know, they're trying to state, if I think this was probably in their original messaging, right, in 2020, if you had data from 2019, you could still upload it. They did recommend, obviously, if you have an upcoming survey for transformation or even annual reporting, that you contact your representative to determine if there's any additional accommodations that should be made. Ideally, I'm assuming longer extensions or kind of a shorter look back period, but they'll determine that on a case-by-case basis. Now for the annual update, besides the annual reporting changes that Carly looked at, they did make changes to the standards and guidance each year. This year actually did have quite a few changes, I would say. It's summarized in the table on your screen on the left. Some of the ones that I'll point out, they did add a lot of sections to different policies and procedures and also different criteria on natural disasters and cybercrime. I'm going to go with COVID-19 influence the natural disasters possibly, with kind of that kind of mindset in place, I would assume, and also the major increase in cybersecurity and ransomware attacks with the cybercrime. So they updated that policy. They also, again, with COVID in mind, updated policies and procedures on entirely remote operations. A lot of behavioral health updates throughout on both the behavioral health distinction as well as throughout the main criteria. Most of them are elective. They did update the list of clinical decision support examples in the guidance that had been asked for by a lot of practices as well. And then last but not least, one thing I wanted to point out with the QI activities that we had talked about, they did actually add for Appendix 5, they outlined specific measures in that table. So that's the table you're seeing on the right. These are all ECQMs that are currently supported by NextGen's HQM, which makes it really easy for NextGen users. But these are the measures specifically that will allow you to meet the QI criteria requirements much, much easier. So again, no major changes, I would say. There was a slight change, though, in accessing the standards and guidelines. Those now are available at a cost. Originally, they were a free download. So if you do need access to those, just be prepared for that. And then these changes are effective for practices enrolling starting January 1st, 2022 onward. So if you're starting, it's that weird cutoff time. So, if you're in annual reporting within 2021, that has a whole different set of requirements from last year. The annual reporting requirements, and then these changes are for 2022 moving forward. So now, how can we help you? This was obviously a lot of information on both transformation and annual reporting. So we and NextGen want to make it easier on your practice. So the first thing we'll talk about is this pre-validation program. I think we've hinted to it enough throughout the presentation to not really go over this in too much detail. NCQA offers pre-validation for certain EHR vendors to help assist practices go through this. And that basically allows practices to claim what are called transfer credits as evidence for certain criteria. So not to give away any secrets, spoiler alert, NextGen Healthcare is pre-validated for the NCQA PCMH program. We actually have transfer credit approval for 31 PCMH criteria, and that includes 15 out of the 40 required core criteria, and then 16 out of the 25 elective criteria. There's also what's called practice support. This is labeled by NCQA to basically say this, basically they're saying NextGen demonstrates aligned functionality that significantly supports the practice in meeting a criteria. They just couldn't give you automatic credit, likely because you just have to show them that you're using it. So then you have additional practice support approval for an additional 21 criteria. You also have NextGen Office EHR as well, but I didn't see anyone on the list here today that was on NGO. So this is great news for NextGen users. They actually have on the success community a chart that shows the pre-validation overview. If you are in the transformation process, you do need to request this pre-validation letter by opening a case on the success community, and they will get this over to you so you can submit it and upload it to NCQA, and they'll automatically mark criteria and Qpass as met. They also, on the success community, have the PCMH capabilities matrix. This is going to show you what's available for transfer credit or what's labeled as practice support credit. Again, this is a great idea. We immediately emailed this over with that letter to our NCQA rep, as well as our uploaded to our evidence library. And then last but not least, NextGen also has a PCMH report solution. I took out the word new around it because I don't think it's no longer new. It's been around for a few years, but NextGen does have a comprehensive package of PCMH reports that will help you meet a lot of the criteria. It'll give you a reports guide and also a report specification document as well. So this is the reports that are included in that reporting suite. You can reach out to your NextGen account manager, or if you're one of Attentive's clients, to look at possibly purchasing the PCMH reporting suite. But those criteria are the ones listed there that it would help you meet. And then last, but I hope not least, your very own PCMH certified content expert. I've been certified through NCQA on-site training and an exam to assist practices. You know, what can I or we do? Honestly, it's whatever your practice needs. Carly and I tend to work as a team. We really assist in, you know, helping to figure out if you're prepared to enroll and begin transforming. We can really, our strength is, you know, helping figure out your pace and establishing a work plan. We like to help you identify what evidence should be prepared in advance and kind of what will be demonstrated and get everyone organized and on the same page. We would definitely help you participate in your virtual check-ins and assist your practice in your evaluation. And then obviously, you know, help your practice if you need it to plan for annual reporting. So if you are thinking of recognition, feel free to reach out and let us know. Kind of our next steps here. We know this is overwhelming. If you're uncertain where you stand, we can provide those recommendations and assist you with those new processes and procedures. Our next steps, I would say, if you are interested, obviously you can visit our website and you're on our webinars already, but we'll have our contact information on the next slide when we get to questions. Feel free to email either of us directly if you have any questions or you are interested to see, you know, your transformation process or want any assistance. Besides PCMH assistance, you know, we do help out with MIPS. We also have on-site consultations that some practices have chosen to do prior to PCMH transformation on clinical workflow, revenue cycle, and technology and performance. Okay, I've made it to questions on exactly the end time. So I don't know if we'll have too many. If we do run out of time, feel free to email me directly. I know Carly might have to drop off here, but I will stay on as long as we have questions coming in. So I am going to go ahead and turn it over to Chelsea, but thank you all for joining today. If you do have to drop off, again, my email is on the screen if you need to email me directly.
Great, thank you so much, Lindsay. And again, thank you everybody for joining us today. As Lindsay said, we are at our time, but we're gonna hang on and be available to still answer questions. So feel free to ask any that you have. You can type them in the questions area of the webinar control panel, and we're just gonna go through them in the order that we've received them. So far, we only have a couple, so if you have burning questions, we can answer them. Well, hopefully. Okay, Lindsay, first question. How long do we have to complete the transformation?
Perfect. So I'm not sure when that one came in, but you only have 12 months technically, and that time starts as soon as you on Qpass sign and pay. So I stress this because you know, you can go ahead and set up your Qpass account, get everything in order, and just not sign and pay, or you know that you're gonna participate and transform and start getting things in line and at least have some core criteria done before you go ahead and set that up and sign and pay. But that 12-month clock starts as soon as that payment is submitted. You can purchase additional time though if you need.
Okay, great. And it looks like this might be our last, but again, we'll hang on just in case people are typing as we're talking. Okay, so hi, just wanted to say thank you for this webinar. It's very helpful. Yay. Our practice is transforming now, and we have an NCQA rep assigned to us. You mentioned something about an NCQA evaluator in the slides. Is this the same person? I thought a rep conducted our virtual check-ins.
Yeah, so this is actually a point of confusion. Honestly, even the amount of times that I know the difference between the two, but once I was actually helping a client, it can get confusing. So in Qpass, when you have contact your NCQA rep, this is going to be your point of contact for any questions about the process. Sometimes they might be able to help you with some evidence questions as well, but typically this is going to be your NCQA resource for questions like how to set up a virtual review, or you know, something looks different with my account, something kind of logistics wise with the transformation. They're on your side, they're on your team essentially. Your NCQ evaluator is a completely separate person. Your evaluator is who's going to determine if you've met or not met certain criteria, and that's the person who's looking at the things you upload, and then also who will conduct your virtual review. So they are two separate people. You actually won't be able to be in contact with your NCQ evaluator before or after, you know, your virtual reviews. That's the only time you see them. Your NCQA rep, on the other hand, you can talk to or reach out to whenever you need.
Okay, perfect. Oh, looks like we just had another one that came in. One of our most difficult aspects of reporting NCQA PCMH, or actually anything that deals with patient metrics, is I can't find a way to tie a patient to a site to report by site. Some of our providers float to multiple sites, and so we can't just tie one site to a provider. Is that something that maybe you've dealt with? Maybe this is not the right platform for this question.
Nope, I can go ahead and grab that. That is one of the hardest things. Empanelment of patients is extremely difficult. Some practices take different approaches to how they actually empanel patients. This is something I would rather take offline and answer, you know, personally of what challenges you guys have had and what your current situation looks like. It is a great question. Like I said, paneling patients is one of the most difficult things. It sounds like you would definitely need multi-site eligibility for PCMH with providers floating around and patients floating in between sites as well. And that's typical. It happens all the time. So PCMH or NCQA sees that and is usually fairly easy to work with. And then they'll guide you on how to empanel the patients and what's best. But that's something, feel free to email me directly as well and we can discuss further.
Okay. Well, thank you everybody again for joining us today. And if you have any follow-up questions, like Lindsay said a few times now, you see her information up on the screen along with Carly's. You can also reply to my email that I'll be sending within a couple of days here with a link to the recording and slides. Basically, any way you can get a hold of us, we're happy to help. That's why we're here. We truly enjoy doing this, so don't hesitate to reach out to us. And hopefully we'll see you at some of our upcoming webinars in September.
Yes, thank you everyone for joining and have a great day.